So thank you everyone for listening in. And I'm really happy to welcome Professor David Crabb with us. Professor David Crabb is Professor of Statistics and Vision Research in the School of Health Sciences at City University in London. He completed a PhD in Statistics and Visual Science at City University in 1996. And following a postdoctoral position, he took up a lectureship at Nottingham Trent University before returning to City in 2005 and was made professor in 2010. He is now head of the Crabb Lab, which you can find on Twitter, at City University, and consists of a mixture of researchers from optometry, psychology, mathematics, health economics, and computer science backgrounds. And I have to say, David has one of the most impressive labs in the UK working in this field. And what's really struck me about David, working with him in the past, is that he has a really unique perspective of disease. And his research, despite being a non-clinician, focuses on what matters to patients. And I think that's why he's been hugely successful with grant funding from various organizations, including the NIHR. So thank you, David. And we're looking forward to hear about visual fields, armchairs, and big data.
Thanks so much, Riz. Just the obligatory check that you can see see my slides fine?
Yes.
Yeah, good. And first of all, thank you so much, Riz, for inviting me to present at this seminar. It's really nice of you, and you have to forgive the sort of lockdown look of long hair and beard here that I have. I'd also like to say that apart from being a brilliant clinician, Riz Malik spent a period in London, probably 5, 7, 10 years ago now, and I was very lucky that Riz spent some time working with us at City, and during that time we realised not only did he what was it that he was a very good clinician scientist, but he was also a very good vision scientist as well. So it was my pleasure to sort of work with Riz during that time. Anyway, I'm going to be talking about visual fields in glaucoma with this kind of intriguing idea of big data and armchairs. So let me just make sure we are moving forward here. So, okay, sorry about that. So I'm going to be talking about the burden of glaucoma, and when we talk about the burden of the disease, first and foremost, the burden really lies with the patient. First and foremost, the burden of the disease is definitely something that's held by the patient. And just going off on a slight tangent here. There's another burden, of course, to glaucoma, and that is to the patient's sort of informal caregivers. In other words, their family, the husband, the wife of the patient, the son or the daughter of the patient. And this was some really nice work that one of my PhD students, Leanne McDonald, did recently, where she looked at this kind of hidden kind of burden of glaucoma, and that is on the patients as well. So I think when we talk about the burden of disease, we've got to talk about the patient, but we've also got to talk about the families of patients as well. But the burden I'm going to be speaking about this evening is the burden that the clinician has of looking after large numbers of glaucoma patients. So the real burden is this monitoring of glaucoma. And in the UK, we have a population of about 70 million people. And this figure here that's on the screen tells you that there's 1 million hospital visits every year for glaucoma. So it's a huge burden just managing these patients. And as this audience well knows, glaucoma is a chronic age-related condition. And, this burden isn't going to go away. There's just going to be more and more of these patients as we move into the coming years. And this is some real footage of some patients trying to get into a glaucoma clinic back in London. Now, obviously, that's you know, kind of a bit of a joke, really, and it's actually probably a joke in quite poor taste in the current circumstances, because we've got this burden of all of these patients, and now because of the situation in post-COVID-19, we've got to kind of think about how we're going to look after all these patients in a situation where we don't want large numbers coming together. So we've got this burden of monitoring glaucoma, and what do we do with these patients? You know, how do we actually follow them? What do we do with them? Well, the main obsession is with intraocular pressure, with IOP. It's an obsession, and I use that word obsession because, after all, that's the only modifiable risk factor for the disease. So it's a reasonable obsession because that's all we can really treat. At the same time, we've actually got some research evidence to show that it is an obsession. So this was some nice work, actually, that Riz Malik did with Richard Russell when he was in my lab back in 2013. And in this study, what we did is we looked at how different hospitals handled their glaucoma patients. And simply put, what we found is that there was this, that any kind of decision that was made about whether a patient's treatment would be intensified or not, or how often or how frequent a patient would be seen, was always related to changes in intraocular pressure. So in other words, what I mean is, although we know that the optic nerve is at the center of this disease, and we have good ways of tracking what happens at the optic nerve, you know, very rarely in our clinics in the UK is an assessment of the optic nerve really used to monitor a patient with glaucoma. The main point that I want to make this evening or this afternoon really is that I think the most important measurement that we should take when we're monitoring patients with glaucoma is the measurement that we get from automated perimetry. In other words, I would argue that a measurement of the visual field is critical when we're trying to manage our patients with glaucoma, and decisions about whether a patient's treatment should be intensified or not should be really hinged on perimetry, because after all, this is our measurement of a patient's visual function. You know, this is our best guess at knowing what the patient can actually see. Having said that, anyone who kind of knows me would say, well, yeah, you would say that because perimetry is kind of my research interest. So much so that I belong to this thing called the International Perimetry Society. And believe it or not, this is like a club of people who are just interested in perimetry. Now, you know, I'm sure you're all very normal people, but you wouldn't go along to a conference such as this, where incredibly, you know, we spend 2 or 3 days just talking about perimetry. But it's a bit like any research meeting. It just ends up people having a good time and people dancing and stuff like this. But anyway, it's not just me who thinks perimetry is important. Again, this was a really nice piece of work that Rizwan Malik did when he was in our lab. And this was really a survey of glaucoma specialists and glaucoma consultants. And in that survey, we were trying to find out what they felt was important when it comes to managing patients. And all of them kind of agreed about the importance of the visual field in terms of measuring patients' visual function. But they also recognized the difficulty of measuring visual fields, and the fact that the resources that were available to measure visual fields were not sort of optimum. But they certainly recognized that visual fields were important. And we also know that when it comes to the clinical trials for new treatments for glaucoma, then again, visual fields are critical because they're probably the only really recognized endpoint that we should use in clinical trials, because these are what we use to measure a patient's visual function. And what about the real experts? What do the real experts think of automated perimetry? Well, the real experts are the people who have been spending all these years pressing the button, really. And I thought I would just highlight this paper, which was done by Fiona Glenn in my lab a few years ago. And this was quite an interesting and novel study, because we actually asked patients, you know, what they thought about their monitoring in glaucoma clinics. And you wouldn't be surprised to hear that patients found visual fields often challenging to do. They found them kind of difficult. visual fields caused quite a bit of anxiety, and generally their feeling about visual fields was that it was their least favorite part of their glaucoma visit. At the same time, the reason why I think this paper is useful, and it might be useful for any of you who are running perimetry services, there were patients who did talk about the positive aspects of visual field testing, and it often hinged on the way the clinics were organized themselves. So in particular, patients who had a positive experience of perimetry testing talked about the importance of supervision, about the environment with which patients were tested. In other words, making sure that the space and environment was suitable for them to carry out what was an examination of their vision. And the other little thing that I just want to highlight here is that a lot of patients were concerned about the fact that it seemed to me that they hadn't ever seen their visual field results. So some patients sort of talked about the fact that the fact that they'd never seen their results made it more difficult for them to engage in this sort of examination process, really. And I think this is something that's worth sort of remembering when we're running perimetry services, about the importance of sort of showing patients their results. The first part of this talk, the kind of big data part of this talk really, hinges on a study that we conducted about 6 years ago now. And again, this is another kind of positive for visual fields, because this technology has been in our clinics for about 30 years. And it means that all these visual field results that we've collected over that period of time might be able to tell us something about what's actually happening within the clinics. So for the first part of this talk, I want to talk about this one research paper that we published in 2014. And this was some nice work that was done by Luke Saunders and Richard Russell in my lab, along with a really nice collaboration between different hospitals in the UK. And what this research paper showed to me as a non-clinician was the enormous variability that we have in our patients' visual field measurements and how they progress over time. And the other thing that it kind of taught me was the importance that most patients, once they're treated, once they're actually in clinics and being treated, then most of them are not going to be visually impaired in their lifetime. So let me tell you a little bit about what this study entailed. So this study actually used a very large archive of visual field results that we managed to extract from different hospitals in the UK. So we ended up with, I think it was around about 750,000 visual field tests that we managed to curate and put together in a large archive. So you can imagine, for like a boring research person like myself, this was a brilliant resource, because we had this, 750,000 kind of data points from patients. And when you've got these really large data sets, you can do some sort of quite interesting things. So let me explain what we did here. So this is just one eye from one patient in that huge database of visual fields that we had. So this is just one eye. And what we're doing here is, on the vertical axis here is the mean deviation, or the summary measure of the visual field. And along the bottom of the graph, we've got the age of the patient. So when this patient first came into clinic, they were about 67 years of age, and they've had a visual field every year in this particular eye. So they've had annual visual field testing, they've had 5 visual fields, and this is what's happening to the visual field over time. So we can see at the top, if we just look at the grayscales, that the visual field seems to be getting worse. And this is reflected in the fact that this MD, as we've plotted it over time, is going downwards. The next thing we can do is that we can kind of fit a line to those points to kind of give us an idea about the speed with which the patient's losing their visual field, or the velocity with which the patient is losing their visual field. And we can get this line, and this gives us like a trend of what's happening over time. So we've now replaced that one eye with this slope, and this gives us an idea of what's happening at that particular eye. The next step is to actually then go back into the database and look at all the other eyes. So I've plotted some of them there. So these are from some younger patients. And what you'll notice here, this is a bit weird, because some of the slopes seem to be going upwards here, for example. This slope over here is sort of quite interesting. This is a patient who's very elderly, but they've got like a catastrophic loss of vision in their eye. but they're already reaching an age of in their early 90s there. So we can keep adding sort of eyes to this plot and keep adding them and adding some more. And then we end up with this rather kind of stupid graph, really, this kind of big, stupid, hairy graph. And the reason I show you this big, sort of stupid, hairy graph is to give you an idea about the enormous variability that there is in how patients lose vision in our clinics. So there's no point talking about like average loss of vision because of this huge variability. Of course, your dilemma as a clinician is actually trying to find those really fast, rapid progressing patients in amongst this kind of huge haystack of points. When we thought about this, we thought, well, let's try and take this a little bit step further. Could we kind of add some extra things to the model here? And what we really want to know is how the speed of loss is going to affect the patient in their particular lifetime. And we've also got to bear in mind that the patient's got two eyes in terms of their visual function. So what did we do? So as part of this modeling exercise, what we did is we looked at actuarial tables or insurance data to give us an idea about the patient's residual expected lifetime, so their residual life expectancy. So for this particular patient, 72 years of age, we go to the life tables, we predict that this patient has reasonably another 15 years of life. And then what we do is we project forward what's happening to that particular vision and extrapolate it to their predicted end of life, really. And if we do that, if we look at the left eye, now though, the left eye is remaining stable under treatment. So this is a much more stable slope. And if we project that forward, then we end up at this point. So I would argue that in terms of visual morbidity, what the patient can actually do, the patient's visual function, is probably more driven by this yellow symbol than the red symbol. So in other words, this patient is probably likely still to be able to drive, for example, by their predicted end of life. So how do we put all this information together? So we put all this information from this model into this graph here. Now this graph's a little bit complicated, so let me try to explain what's going on. Each dot on the graph, or each symbol on the graph, represents a single patient. And on the vertical axis, I'm plotting the mean deviation in the left eye. So if, according to our model, a patient's left eye is getting worse over time, then they would go in this direction. If their right eye was getting worse, then it would go in this direction. So in other words, if their right eye was getting worse, then they would move in that horizontal direction. So I'm not sure if I've explained this very well, but to understand this graph, if you was an actual patient on this graph, if you was an actual person on this graph, where would you not really want to go? Where would you not want to go on this graph? Well, you wouldn't want to go down here because this means that both your eyes are losing vision rapidly over time. And for this graph, the way we introduce time into this graph is with motion now. So you'll see all these dots starting to move around now. And it's a little bit mesmerizing when you look at it for the first time. It's a little bit mesmerizing, but have a look at it as it loops again. So as it starts, notice around about here, around about 15 years, if you look closely, most of the dots have actually stopped moving. So what does that mean? Well, that tells us that the model has kind of predicted that patient has reached their end of life. So it's a bit of a kind of a gloomy sort of a graph in some ways, but it kind of gives you an idea that patients who are losing vision, may never get down in that bottom right-hand corner because they're already quite elderly when they've had their diagnosis. The next thing that's interesting about this graph is all these green points that seem to be shooting up into the ceiling. And this seems a bit weird, but these are the patients that are actually kind of highly variable when they're doing the measurement testing. So, or they're actually learning to do visual fields. So that they're all kind of shooting up in the opposite direction. And that's good in a way, because we know that their vision is certainly stable and not getting worse. And by now, and there's a lot of those, there's a lot of patients that are learning to do perimetry and being sponsored to be learning to do perimetry in our clinics when perhaps they shouldn't be doing perimetry because their vision is fine. So I guess the point that I'm clumsily making here is that the ones that we should really be concentrating on are those red dots that are ending up in that bottom sort of right-hand corner of your screen. And about 1 in 20 patients are going to reach a point where their visual field is worse than -20 decibels in both eyes. But where do you draw this line? You know, why do we draw this line here? You know, really, we want to have some other better kind of milestone of vision loss. And this, again, was some nice work done in my lab by Luke Saunders. And what he did was kind of work out what kind of vision is required to satisfy the legal component for visual fitness to drive in the UK. So in other words, patients ending up in this part of the graph, you know, are going to lose vision such that they're no longer legally allowed to drive. And so here now the figure is a bit more depressing, really. 1 in 8 patients in our clinic are going to reach this milestone in their lifetime according to this model. And it's very interesting when you start looking at this graph. If you look at that top left-hand corner there, that's a kind of a bit weird, because if you look closely, there are no red dots in that top left-hand corner. So what does this mean? Well, this means that all the patients that ended up in the bottom right-hand corner, they all started off with visual field loss of at least worse than -6 decibels in one eye. So in other words, most patients that are at risk of kind of getting to the point of having visual impairment have already lost a lot of vision in one eye. So this is kind of interesting. It's certainly interesting for me as a non-clinician, because I think about all of the resources that we use in clinic. Then maybe we should be shifting some of these resources into the community in order to make sure that we don't have patients coming into our clinics and hospitals where they've already lost a lot of visual field. And I'm sure many people in this audience have come across this patient that's lost lots of vision, lots of their visual field is quite poor in, say, one eye, but the patient has generally been asymptomatic. And, you know, at that stage, you think, well, if it would have been better if we could have started to treat this patient earlier. And in the interest of time, I'm not going to talk about this particular study too much, but we actually went on to say, well, you know, are we getting any better in the UK at identifying patients with glaucoma where they don't have advanced visual field loss when they first come into clinic? In other words, you know, what is the level of visual field loss in patients when they first come to clinic? And again, we went back and used this large data set. And this time we were interested in what the visual field was like in the very first time that they were in the hospital. So we took this as like a surrogate, I guess, of whether the patient had early visual field loss or severe or advanced visual field loss. And in particular here, we were interested in looking at the worst eye in the patient, because that would be the most detectable eye. So again, you know, very impressive numbers. We had 25,000 patients like this, and we could look at the way in which this may have changed over time. And that's reflected in this graph here. So the proportion of patients with severe loss or early loss over the decade of data that we had didn't actually change a great deal. And this is a bit depressing, really, because in particular, I'd like to focus on that number down here, this 22%. And what that tells me is that 1 in 5 patients come into UK clinics where they've already got quite advanced visual field loss in one eye. And we know from the other modelling work that those are the patients that are more risk of losing vision in their lifetime. So I would argue that certainly in the UK, what we need to do is we need to think more about trying to kind of detect visual field loss before it becomes advanced. And I think that's kind of something that probably any health service would be a good goal to try to achieve. And again, in the interest of time, I won't talk too much about this particular paper, but when you've got these large data sets, you can start to ask other questions about whether there's any kind of trends in the way in which we might treat patients. You know, are our treatments over a period of time much more effective, for example? Well, again, this data revealed that actually there wasn't a great deal of difference in what happened at the start of, say, 2000 compared to 2010 in terms of how quickly patients were losing vision. And I don't want to talk about this paper too much, but I do want to focus on these little graphs. And these graphs are pretty boring to look at, but they have a very important message. So what we have here are 3 pie charts, and it tells us about how many patients were getting very frequent visual field testing. So typically in the UK, a patient would probably get a visual field test annually, one visual field test a year. And they're represented in these rather boring blue, pie charts by the blue areas. And then these red areas represent the patients that are getting more frequent visual field testing. So the proportion of people in red are the ones that are getting more frequent visual field testing. And what's interesting is if you stratify this by age, there doesn't seem to be much difference. So, you know, it doesn't matter whether you're a younger patient or an older patient, everybody seems to be getting the same kind of diet of visual field testing. And it becomes even more worrying when we split it by whether the patient has advanced visual field loss or whether they have early visual field loss. So according to these data, you know, patients were getting just as much visual field testing if their vision was really bad compared to maybe whether they were an ocular hypertensive or a suspect. And these three pie charts, I think you'd agree, they all look the same as well. And this is even more depressing, really, because it seems it doesn't matter whether a patient is progressing fast or whether they're progressing slow, they all seem to be getting the same kind of diet of testing. So I think that was a rather laborious way of me saying that actually something we really must start to think about in clinics is how we use our resources, and in particular our visual field resources. This was some really nice work done by Trishul Budner in my lab, and if you're interested in money, it's a kind of a nice paper to look at, because we actually took these modelling ideas a bit further and did some kind of health economics on this. And what we showed is that not only could you make better clinical decisions in some groups of patients if you saw them more frequently and you could save money, but also some patients, you know, should do less visual field testing or no visual field testing at all. And again, that would actually save, not only make better clinical decisions, but you'd actually save resources and money as well. So I guess the point, Riz, I'm kind of clumsily making here is that lots could be gained by stratifying our resources better in clinic, in particular visual fields. And again, I don't really want to dwell on this too much in the interest of time, but just to say that I think until we start having data like this in our clinics, we can't really start to think about how we can improve our clinics. This isn't just for visual fields, but I think the more we know about the kind of measurements that we take in our clinic, the more we can start to think about how we can improve our clinic. And this was some really nice work. This is just a bit of self-publicity, really. This is another really talented PhD student in my lab called Stephen Kelly. And this is a nice paper, which is open access. We try to publish all of our papers open access. So if you're interested in this, you could go and have a look, because what we're doing here is we're suggesting that there could be some really useful ways in which we could audit or assess our service delivery in our clinics. And we've actually provided or developed some tools for this. So it's quite satisfying, actually, that some of these graphs and things that I'm showing you today, you know, are actually starting to be used in the electronic patient records that we use back in the UK. So now I'd like to go on to the sort of second and final part of my talk, in the hope that I'm not talking for too much here, and that is, are there alternatives to visual field testing? You know, what you have in front of you here is the kind of standard perimeter that we use in the UK, the Humphrey perimeter, and we don't want to kind of replace it completely, but is there a way in which we could maybe improve perimetry or augment it in some ways? And lots of people have thought in the past about trying to do perimetry or do visual field testing in a more portable fashion. So using something like a laptop or an iPad or a tablet. And there are others who have kind of thought about, is there a way in which we can improve the patient experience with perimetry? In other words, can we use eye movements to assess whether patients, assess a patient's visual field? And what we've been doing, occupying ourselves with in the last few years is to develop this thing that we called eye catcher. And the idea here is to combine those two things together. Can we actually do a visual field test on a small portable device and remove the button pressing? Can we just use an eye tracker? And this is what we've come up with. So very briefly, the idea is that you look at this kind of portable device, which is like on a laptop computer or a tablet computer, and the instructions are very simple. We just ask a participant to follow the dot as it moves around the screen. And then what we do is we use a very inexpensive eye tracker to monitor the eye movements. And we can then look at those eye movements to see whether the patient has actually seen the stimulus or not, depending on where their eye gaze is at that particular time. And that's a very short and somewhat clumsy way of describing a way in which you can build a visual field result simply by asking someone to move their eyes around following this stimulus on the screen. And for those of you who are interested, you can go away and you can find the paper where we published this first piece of work on eye catcher. It's some really nice work that's mainly been done by Pete Jones in my lab. And what we did with this study is we found that there was pretty good concordance. There was good correlation between our measurement of the visual field using eye catcher and the standard Humphrey test. So we showed that there was a good correlation between the two. The problem with anything like this, when you develop a bit of technology like this, and as a kind of a vision scientist, we get kind of excited about it, and we recruit people to come into the university to do these tests. But the whole device will either stand or fall how it actually works in a hospital. So that was our next study. We thought, can we take eye catcher into the real world? You know, how would it work in a hospital environment? And the real world was this clinic that we used in Guildford. And so we actually spent, I think it was about 12 weeks going into this clinic and trying to get patients to do this eye catcher test whilst they are in the waiting room, really. And this was a really nice collaboration with someone called Dan Linfield in Surrey. And I'm pleased to say that the paper is about to appear as well. Essentially, we did this in about 80 people, and it was purely cross-sectional. We just invited a patient to do the test. There was no kind of inclusion or exclusion criteria, and we got the patient to do the test in one eye, and we tested it twice. And the results are just about to appear in the British Journal of Ophthalmology, and I'd like to share some of the results with you. So again, this is just one eye of one patient. So this is their Humphrey result that you can see in front of you here, and this patient has this inferior sort of nasal step area here. They definitely have a visual field defect on Humphrey, and this is the result from the eye catcher test. So the eye catcher test is a supra-threshold fixed stimulus test, and I'm not going to go into the details, but essentially the red parts represent where the scotoma is. And notice we can't measure out to say 25 degrees of the visual field or 30 degrees. We're restricted by the size of the screen for the portable device, but nevertheless, there's quite good concordance between the two, and there was good repeatability. So here's another visual field of another eye, and again, you know, eye catcher picks that up quite nicely. Even someone here with a much more advanced visual field loss in their inferior visual field, again, is picked up by eye catcher. And this is where it becomes interesting. So this is a patient that was in the clinic who didn't have glaucoma. They've been falsely referred by their community optometrist. You know, they had normal pressures, normal discs, and then they did a Humphrey and they had a normal visual field. And what was good is that they also had a normal eye catcher as well. And here's another example of a patient that's kind of clogging up the clinics. This is a patient that's been falsely referred into the secondary care. And again, you know, they've got a normal visual field. And the good thing is that eye catcher is normal as well. So what am I getting at here? Well, this is a very complicated graph, and I don't really want to go into the details of it, other than to say that it's like a representation of the concordance between what happened with the Humphrey and our eye catcher test. And this big green space that I've highlighted in front of you here tells me one thing, and that is that if a patient passes the eye catcher test, if they do this very quick portable test, then actually they don't have any visual field loss. So in other words, we didn't find anyone who passed eye catcher and then went on to do the Humphrey and actually had a visual field defect. So this is really good because it sort of suggests that this could be a really useful way of a triage for patients, really. So if a patient did this very quick test in the waiting room and they passed, then probably, you know, they're almost certainly going to pass the Humphrey as well. So this kind of suggests that this kind of technology would be very useful as a way of kind of sifting out which patients might need more testing than others. And this rather busy graph down here just tells us that the patients much preferred doing this test. You know, they felt it was more like a computer game to them rather than doing an actual visual field test. The downside is that around about 10% of patients, eye catcher simply didn't work. And the reason it didn't work is because of the actual eye tracker itself. So we deliberately used a very inexpensive sort of eye tracker, which people would use for computer games, for example. And sometimes the eye tracker just simply doesn't work. And yet I would say in a triage situation, this wouldn't be a problem really, because if you couldn't get a result from eye catcher, then you'd probably go on to do the Humphrey anyway. So once again, that's a paper that's going to come out pretty soon. And we think, you know, that's an interesting application of this technology. The final sort of 5 minutes or so, I just want to talk about how we might be able to move some of this technology into patients' homes. So this is the armchair part of the talk, really. You know, is it possible that we could actually take some of this portable technology and get people to do their visual field testing at home? This is a very, you know, sort of seductive idea, really, because not only would they wouldn't have to come into the clinic, but it might allow them to kind of monitor their vision much more carefully at home. So this is a study that myself and other colleagues in the lab have been doing for about a year or so, really, funded by the International Glaucoma Association. And the approach that we wanted to take here is, could we actually get people to do a visual field test, you know, in their armchairs at home? That was the plan. That was the first kind of objective. And then the second thing is, could we do this in a very inexpensive way? You know, we didn't want to use any kind of sophisticated technology. In other words, we wanted to do something that was almost like second-hand visual field testing. And the idea was that we wanted to fake the visual field. We wanted to have a complete inexpensive fake visual field machine. And that's what we've come up with. And here it is in the bottom corner of the screen here. So it's still the eye catcher, but we don't have the eye tracker now. It's replaced by this button, but everything else is very, very simple. And the idea is to use the most inexpensive computer we could find. So the computer that we use is about £350, really. So it's a very inexpensive computer. So we're not using any kind of expensive screen. And we tried to fake the Humphrey. We tried to replicate the Humphrey. And this is what it looks like. So down here, you've got two eyes of the Humphrey, and these are the results from the eye catcher test. So this is a threshold test now. So it's no longer a kind of screening super threshold test. This is a test where we're actually trying to measure the depth of the visual field. It's not all kind of cheap and inexpensive though, because we've also got some kind of clever ideas that have been built into the test. So this is another paper that's just about to come out in TVST. And the idea here is to use the webcam. So as part of this test, that's not using the eye tracker, that's just using the ordinary webcam to see how adherent the patient is. In other words, you know, are they looking like this, or are they actually doing the visual field test? And we're quite excited about this because there's a nice relationship between, you know, where the patient is looking on the screen and how reliable their test is. The actual study is really kind of interesting because we managed to recruit 20 people and we gave them the eye catcher test, and then we asked them to do the test once a month for 6 months. That was the aim of the test. And we're also doing some interviews at the end of this, and we're just about to publish some of the work on this to try and get an idea about whether patients thought it was a good idea or not. And for me, the most remarkable thing about this study is that we gave 20 of these devices to patients, to 20 people, and at the end of 6 months, we got 20 devices back, and nothing actually broke. So this in itself was a big achievement because we managed to give people these devices. They managed to do this test every month, and we actually got some really good data back from all of them. And I'll just quickly share some of the data here. So what we did in this study is that the patients did a Humphrey test at the beginning of the study and then a Humphrey at the end. They did 2 Humphreys actually, 2 Humphreys at baseline and 2 Humphreys at the end of the follow-up. And then in between, these are the eye catcher results. So if you just glance at them, you can see that, you know, there's pretty good concordance between what the results were at home and the results that we did with them once they came back into the clinic. And this is a rather busy graph, but what it shows you is the mean deviation from the eye catcher and a Humphrey. And what it showed is that for most patients, you know, there was pretty good kind of concordance between what you would have got from the Humphrey and the eye catcher test. You know, there were some patients, this patient, for example, they gave up the study at the end. They didn't actually do some of the tests, and some of the results are a bit irregular as well. But the interesting thing is that there was good concordance between the two. And I'll finish, if I may, with this graph, because this graph's a bit complicated, but it's got an important message in it. And this is actually the retest variability between the Humphrey fields that we did at the beginning of the study and the Humphrey fields at the end of the study. So in other words, this graph here gives us an idea about the variability between two results when you're just using the clinical instrument. And we can see this is the variability. And here we're just using one Humphrey. If we used two Humphrey, so if we were in the fortunate position of doing two Humphrey fields every time a patient came into clinic, then unsurprisingly, this variability narrows and we get more precise measurements. So if we do more Humphrey testing, we get more precise results. But I'd like you to compare it to this. So this is the results from the eye catcher test. So what I kind of clumsily got at here is that if we get patients to do lots of tests at home, then it improves the precision of their results. So I could imagine a situation where perhaps some patients, you know, you could actually get them to do their visual field testing at home, and that could augment the kind of visual field testing that they're doing in the clinic. And I think this could be particularly helpful if you were running a clinical trial, for example. So we know that clinical trials in glaucoma are always going to be long because glaucoma is a slowly progressing disease and the measurements that we take are highly variable. But maybe we could do something where we could actually get patients to do their visual field testing outside of the clinic to improve our results overall. And if you really want to look at this in detail, and sorry if I've gone on too much about this paper, but we've actually just published this as a preprint. And so you can go and have a look at this data and have a look at some of the ideas that we've suggested. And in the paper as well, we also talk about this idea of using the webcam in the same way that I'm embarrassingly giving you this talk today. These are not actual participants from our study, but there is some real comedy gold where you have these patients who are saying that they're doing their visual field testing and they're basically sort of looking in a different direction. So I'd like to end up, and I'm very aware that I've rambled on far too long here, but I'd like to finish up by just saying that these are the lab members. As Riz said, we've got a very talented group of researchers who work in my lab, and they do all the hard work. And if you're interested in following anything that we do, then please look us up on the web and on Twitter as well. And finally, just to highlight a couple of bodies that support our research, Fight for Sight and the International Glaucoma Association in the UK, which are rather small eye charities, but they've always been very generous in supporting our research. So sorry if I've gone on far too long there, and thank you very much for listening. Thank you.
Well, fascinating talk, David, as always. Very visual and very easy to follow. Thank you very much indeed for that. So we'll tackle a few of the questions that have been starting to put in the chat box here. So somebody's asked about the eye catcher, whether you see it as a useful screening tool in the community.
So of the two versions that we've been working on, the version where we've been using the eye tracker for eye catcher, the problem is that the eye tracker just doesn't work about 10% of the time. So in a proper kind of screening situation, I don't think this particular technology would work. I think it would work as we try to assess it in terms of being like a potential way of triaging patients. You could imagine that a patient, when they come in, might choose to actually do their own self-automated visual field test. It seems to me it would be like a reasonable piece of technology to say, well, try to do this test, and if they pass that test, what our results show is that they wouldn't then go on to have a foul on the visual field. And I think that's the important. We've yet to come across anybody who's passed the eye catcher test and then actually gone on to show that they've got a significant visual field defect. So rather than a screening tool, I think the real opportunities for this are as a way of sort of augmenting things that happen in clinic and also with home monitoring. At the same time, if it's not possible to do a Humphrey, then the portable and cheap nature of this test would allow you to kind of assess a visual field in a different environment.
And do you have any feeling why the gaze tracker fails in that minority of patients?
Yeah, that's a very good question. So if you noticed in the grayscales that I showed, they were mainly patients that had quite advanced visual field loss anyway. So again, coming back to triage, that's good, because if you foul eye catcher, then it kind of suggests that there's a problem. But then there are some mysterious things as well, Riz. So mascara, believe it or not that I use mascara, but the way in which this particular eye tracker works, it's very inexpensive. It's $100, and it's the kind of thing that people use, in gaming technology. So it's a very inexpensive eye tracker. So I think as that technology moves forward, I would imagine we no longer have to have this business where patients have to press a button. And you know very well from all your experiments that you do in psychophysics that this is where all the variability is. It's this patient response. So I think it's an easy thing to say, but I think as that technology develops, then I think that's the way the sort of visual field testing should be done in the future, really.
So do you see that happening in 20 years' time?
I think so. I think I didn't highlight it, but there are other groups who are actually developing, eye tracking visual field tests. But the problem is, Riz, is that that they're selling them, as expensive as a Humphrey, and that's something that we deliberately didn't want to do. We really thought, well, can we do something as portable, as inexpensive as possible? Because I don't really see how we can, kind of develop something and say, well, this is going to be the same cost as a Humphrey. I think that's pointless.
Yeah, great talk, David.
Thank you, Conrad. Thank you.
As always, I wonder in one thing, usually visual fields depend so much on environment, on stress, on emotional status of the patients, that probably the result, the variability of doing it in your home, in your environment, can be, I don't know, standardized, or the results that came out can be better.
I think, Conrad, it's a really nice observation. And again, it's a nice observation. And what's nice is we've got some research evidence to say that as well, because one of the papers I highlighted, Riz will remember a colleague of his very well, someone called Fiona Glenn. And she did this study where she basically just got groups of patients together and asked them about perimetry. And what you said, Conrad, is so right, that lots of patients have anxiety about this visual field examination. And, I think, if we can make it kind of an easier process, something that they're more comfortable with, then you're absolutely right. The quality of the data should improve. And I thought it's kind of interesting that we call this a visual field exam. And in that study that Fiona Glenn did, is that what came across quite strongly is many patients never saw the result of their visual field exam. And I think that's another thing, aside from, doing new perimetry, I think something that we can do that's practical and worthwhile in clinics at the moment is to make sure that your patient understands what the visual field test is about. I think a lot of patients, it struck me, and this was amusing for me because I spend all my time doing all this research, but a lot of patients don't even know what the visual field test is. And that's, if we're calling it an examination, they should at least see their results, shouldn't they, really? So it's such a good point. Thank you.
Yeah. So a few people have asked about virtual reality visual fields, and of course there's been a lot of interest in that in the last few years. Where do you see this kind of portable technology in relation to VR kind of visual fields?
Yeah, it's a really nice observation, and if you look us up on the web, Pete Jones has been doing some really nice work, not only using VR but also augmented reality. And the idea here is what we were trying to do with those studies was a very different question. We were trying to give people with normal vision a perception of what it's like to have visual field loss, and trying to work out, you know, is it worse to have a visual field defect here or a visual field defect here? So we were using VR and AR in a different way. But yes, I think it seems like a very sort of persuasive idea that we should be able to maybe do some of these vision testing in a VR environment, because the VR environment would allow you to control lighting, the size of the stimulus. And one of the problems for eye movements is that it's very tricky to track the eyes, you know, in that situation, but that might be a problem that can be solved. But ultimately, I still think that the idea of sort of putting something on someone's head as well, from a practical point of view, do patients really want to be, you know, having the VR experience? You know, some of us who are like interested in VR gaming and new technology, you know, love the idea of putting something on our head. But my experience of doing eye tracking experiments in the lab is that it's quite hard to persuade an elderly person to just put something on their head, really. So, you know, there's those disadvantages. And one last thing is that I was convinced, Riz, that when we gave these portable tablets to patients to do their tests at home, I was convinced that some of them would be doing it in, you know, very well lit environments, and some of them would be doing it in the dark, and that some would be here and some would be back here. But actually, they are all quite consistent, and the lighting didn't seem to affect the results too much. So, so I think it comes back to Conrad's point. I think something that a patient's familiar with could be the key, I think.
Yeah. There is another question here relating the analysis of the static versus the kinetic perimetry. Do you think that it might be some differences between the results?
Yeah, I think again, what I can tell you is that patients are quite intuitive about this idea of chasing the spot around the screen. I think, you know, in a way that's kind of a kinetic stimulus, but it's a very intuitive thing. You just say to the person, just follow the dot. And I think yourself and Riz will know that, you know, one of the problems with standard visual field testing is that you're asking this patient to do something that's almost kind of unnatural. You know, this idea of staring at this spot and then seeing what's, you know, happening out here. This idea of chasing a spot around the screen is something that I think is a much more intuitive way of measuring the visual field. And the other thing I should add is that all of this work that we're doing, we're making it open source as well. So in other words, we are publishing the work, and if someone wants to take this on and say, well, look, you know, I could refine this further, then we would very much encourage that, because you know, the goal always has been to try and make this stuff available for other researchers to sort of look at, really.
Great. Yeah. Very.
You talked a bit about lighting affecting the test, and one of our consultants has asked about, you know, how do you kind of standardize lighting in that kind of test, or does it affect the variability of the measurements much?
So again, please have a look at the preprint of the paper, because it's a great paper, because it's got a huge supplementary material, and I think if anyone judges a paper, they should judge it by the supplementary material. And one of the things that we did, Riz, is, well, not me, but what Pete Jones did, was look at the lighting conditions, you know, from the webcam, and it seemed that it didn't make the difference that we thought it might. There are other restrictions. You know this very well, Riz. The stimulus, we can't get the really bright stimuli on a 300-pound laptop. So you can't measure really deep defects. But you also know, Riz, that, you know, perhaps we're wasting our time measuring, you know, vision loss down at, say, 4 decibels, because, you know, the psychophysicists amongst us know that to measure 4 decibels is a really difficult process. So yeah, it's a really nice question from your consultant, and I'd be great if you could have a look at the preprint, because just based on this 20 people, it didn't seem to make a great deal of difference. I think the webcam is really quite nice, because it gives you an idea about how, you know, the different lighting conditions that patients have been sitting in, but they were remarkably consistent. And I think this comes back to this point that Conrad made, that, you know, perhaps someone does want to do this in their armchair, you know, And if they do it in the one spot and they don't take it out into the garden, then I think you will get like consistent results. And of course the other advantage is that because you're testing so many times, maybe over a 6-month period, then the very fact that the data might be more noisy, but you've got more of it. So this is the boring statistician in me thinking that you'd actually kind of you might be able to pick up the signal better. But the other thing about home monitoring is like the psychological impact of it as well. And these were volunteers. These were people who wanted to do this test. What yourself and Conrad have got to persuade patients to do is to take something home with them. Are you going to get it back? Are they ever going to do it? In some of our other work, when we were doing patient diaries and asking patients to talk about their symptoms, I always remember there was this one patient who said, well, I got really depressed at the end of this because all I was thinking about was my glaucoma. And so, it's all of these aspects. And I think in this kind of post-COVID-19 environment, I think lots of people are going to say, oh, yes, we need to start doing home monitoring. It's a big question. And it's not just the test, it's the kind of psychological impact, the management of it. These tests are useless unless they're in like an electronic patient record, for example. So, there's lots of challenges, even though it's a very seductive idea.
Yeah.
And it's interesting, that animation that you showed, which I found really interesting, that those patients who end up in the bottom corner, the red patients, are the ones who actually start with significant loss in the first place, worse than -6 decibels of loss in either eye. And it's maybe those patients that we should be focusing our resources on, because obviously our resources are limited in regards to visual field testing, and we're still not performing adequately in terms of the number of visual field tests per year. On the other hand, you could argue, well, those patients who have good vision, they need to stay good at doing visual fields, and they need to learn how to do the visual fields. So what would you say to that, Dave?
I'm so pleased you picked up on the red animation, because I still think in amongst all of the talk, I still think that's probably the most important point, is that I don't think, and this is as a non-clinician, I don't think we do what we do in research studies. In research studies, we talk about inclusion, exclusion criteria, and we look at the phenotype of a patient and we stratify. I think in the clinic, it just seems to me that everybody comes in and everybody kind of gets the same kind of testing. And that just doesn't seem sort of logical to me. And I think these patients that are more at risk, just based on their age and where their vision is when they first present, is probably an important starting point. And I'm not surprised that patients get the same kind of testing, because there's a lack of guidance sometimes, or there isn't really the kind of tools that you can use in the clinic to kind of stop and think, well, hang on, this patient's got this kind of disc, that their pressures are here, this is what their visual field is. What you do, and you do it very successfully as good clinicians, is you put all that information together in your head, when I think really you should be able to get some help from some research evidence that's actually in some software that's sitting in front of you, really. So that's a rather waffling way of me saying that I think what we need to do is stratify patients better in clinics and work out, the patients that can't do a visual field test, why put them through the agony every year of making them do it? Just say, well, that's it. We'll stick to looking at pressures for you.
Yeah. Plus, if the results are not reliable, it's useless.
Exactly.
Two other questions here that there are a few questions, but we can probably put two of them together. One is regarding on the learning curve of the test, and one of our consultants is also asking that she wondered if that learning process could affect the anticipation of the results by the patient.
It's such a nice observation by one of your guests there, because we very much underestimate, I think, the sort of learning effect. And for those of you who are not sure what that means, it's basically, your visual field looks as though it's improving over time, purely because you're getting better at doing the test. And you saw in that graph that you've got all these people, these green dots that are just going up into the ceiling. These are people who are learning to do the visual field test. you know, some of them, Riz will tell you, you know, we looked at data where you've got 15 years of a patient and they've been doing the visual field and they're slowly getting better over time. And your consultant makes such a good point, because I think that will become even more amplified in home monitoring. You know, if you give someone like a laptop that they can use and take home with them, then some people are just going to practice and you know, get better. So I think, you know, there's that other challenge as well. I think this idea of doing lots of tests helps, but it will actually amplify the worry about, you know, someone just learning to do the test.
Well, I think that as most of the things we have now, you cannot rely only on one test. You will have to put all these conditions into a clinical scenario, like visual fields, a structural test, and the clinical picture of that patient. I mean, you cannot rely only on the way the patient do the visual field, but of course, the more visual field results you get, and we learn it from the previous equipment, it's usually better.
Yeah, I agree. I think researchers are at fault here, Conrad. I think we spend a lot of our time, you know, writing papers and arguing at conferences. But what we should try and do is try to get that research evidence into kind of tools that you can use in the clinic. In the UK, it's actually kind of we have electronic patient records, but Riz will tell you that, you know, some of them are not very good, and you know, some of them are very different in different clinics. And it seems to me, as a clinician, when you're trying to, you know, fight glaucoma with your patient, it's a shame that you haven't got all these tools and techniques that we often talk about in the research world in front of you. So I agree. I think, you know, something I've been reading about recently is about implementation research, which sounds rather sort of complicated and a bit stupid, but it's so important. I think, you know, we should try and think about how we can get our research that will make a difference to patients, really. And so again, that's a bit of a waffle from me, but I completely empathize with, you know, the situation that lots of clinicians face, and that is that you just don't really have the techniques and tools that can allow you to kind of stratify patients, I think.
Yeah.
So, David, we'll make a last couple of questions. I'm aware that we're probably tiring you out a bit here.
Yeah.
But thank you very much for answering all these questions. So some people have asked about kinetic versus static perimetry. And, you know, coming back to what you said, where you're going to sat in front of a bowl, and for most of the time, actually, you don't see anything, right? And that can be quite anxious for a lot of patients. And, you know, in kinetic perimetry, of course, you see the stimulus a lot more of the time. And do you have any views about that? Like, you know, which technique is more kind of patient friendly?
Yeah, I think the point you make is such an important practical point. You know, as someone who, you know, actually tested quite a few patients in visual field over the years, one of the things is that, and you know this very well, Riz, is this anxiety that patients have when they don't see anything. You know, I think you've got to kind of persuade the patient that, like, the machine is kind of testing like a supervision, really. That and I think that this is a real adds to the anxiety. You know, if someone's sitting there and they just can't see the stimulus. So yes, inevitably, if you have like a fixed stimulus that moves around, then I think I personally think that that's a kind of more intuitive way of doing things, and we've got some data to show it. You know, the patients preferred to do the eye catcher test. So that might be, like Conrad said, it might be because, you know, they don't have to put their head in a big bowl, and it seems like novel to them. But they definitely say, oh, you know, this is good. You know, this was easy to do. I think I think the idea of using a kinetic target is more intuitive, and I think if we're designing new perimetry or new ways of doing things, then that would be the way I would urge someone to go.
Yeah, I mean, you know, we get a lot of children here, and certainly I can see that kind of test appealing to a lot of them, you know.
I think, Riz, you make such a good point. Pete Jones, who's the genius behind all of this, you know, he's done a lot of his work with pediatrics and kids and measuring contrast sensitivity. He's got like a really neat sort of little kind of game, iPad game for measuring contrast sensitivity. And I said to him the other day, you don't want to restrict that to kids, you know, that would be good for adults as well.
So we have one last question here, maybe. So regarding the eye catcher, do you think there's a learning process so that, you know, after several tests, the patient has learned the pattern of the testing and the results can be biased by anticipation of where to look next?
It's a very good question, and I think what we've seen in that preliminary data is that it's not obvious that patients are getting better. It looks like, you know, there wasn't, you know, that's only in 20 subjects, and you know, these are all, I'd call them super patients. I'm sure you've got them in your clinic, Riz, and I'm sure Conrad has. You know, these patients who really, they want to know everything, and so, you know, they were delighted to come and do this test. But again, I'm going off the point slightly, but I think those are patients that, you know, this technology is perfect for, you know, so if they want to invest all this time in testing their vision, then give them something where they can get on and do it, really. It's like when you go into the supermarket, isn't it? You can go to self-checkout if you quite like that, or, you know, you can go to a lady and get your stuff. So I think it's trying to be more flexible. Coming back to the question, it's inevitable that there will be learning and anticipation. And I think, again, it comes back to that question earlier about VR. Perhaps we need to be a bit more creative, not just in the way in which we measure the visual field, but things like acuity and contrast sensitivity. So maybe putting everything together in sort of one platform would be another possibility as well. But they're great questions. Thank you.
Very good.
So I think we've gone through most of the questions there. Thank you so much, David, for the talk and also for taking the time to answer all those questions. It looks like we've had more than 100 people listening in, so that's fantastic. We'll post a video on YouTube in the coming days and send you the link. But thank you so much for the talk again.
Yeah, well, once again, let me just say I'm very grateful for you inviting me, Riz, and thanks so much for chairing it so nicely, Conrad, and also thank you to all the participants who have come and listened, and yeah, thanks for inviting me. Thank you.
Thank you, David.
Thank you, David.
Thank you. Good evening. Bye-bye.
Bye.
Yes. Bye.